Bryn Whitney, Branch Manager and Vice President at Bangor Savings Bank. Bangor Savings Bank has been supporting our local communities for over 172 years, and we are proud to partner with MaineHealth Lincoln Hospital for this 5-part series on coastal medicine in Lincoln County. Bangor Savings is proud to work with Lincoln County Television and MaineHealth at Lincoln Hospital. We hope you enjoy this 5-part series as much as we've enjoyed supporting it. Thank you and enjoy.
Thank you. Well, thank you all for being here. We're really excited to be offering this Doc Talk series. And before we get started, I'd like to just say thank you to Bangor Savings. They are sponsoring our Doc Talk series. And I'd also like to thank LCTV, who is right now filming this. So this can be shown in a series coming up later in the fall. We're really excited to share various things that we've been doing with our providers. And today, and so I'm sorry, I didn't introduce myself, Cindy Wade, Lincoln Health President. I'm very proud of that. I've been with Lincoln Health for 30 years in various roles and have been doing this job just over 3 years. Time flies when you're having fun. So I have the privilege today to introduce Jess Pinkham. Jess is our Director of Surgical Services at Lincoln Health. She is a force to be reckoned with. She has done amazing things in our surgical services. We are so busy on the Miles campus here in Damerscott and very excited. She's done a lot of work recruiting and helping to bring new providers and surgeons to our facility. And so we are doing more and more and more in that small but mighty OR at there's several ORs at Lincoln Health, but it's very exciting and more to come. And then I think she's going to introduce Dr. Ross Feller, but we have Dr. Ross Feller with us today, and we're very excited about that. So I'm going to hand it over to Jess and let her talk a little bit about what we're doing. Great. You ready?
Yep. Thank you. Thank you, Cindy, and also LCTV and Bangor Savings, and all of you for coming out today to learn more about Lincoln Hospital Surgical Services Department. Lincoln Hospital has 3 operating rooms and 1 procedure room, which opened last fall. We are a highly efficient, highly qualified, community-focused team. Our surgical volume has increased substantially since 2019, pre-COVID times. In 2019, we completed 2,334 cases, and in 2024, we are trending to be just shy of hitting the 3,900 mark. This is an increase of 67% in surgical volume. Lincoln Hospital's Surgical Services Department is paving the way with new cutting-edge technology and by embracing the use of artificial intelligence. In 2023, Lincoln Hospital became the first in the state to introduce Ingenuity heads-up visualization system for cataract surgery. This system promotes improved posture and reduces fatigue as surgeons and staff no longer have to lean over the patient during surgery. The team can see the surgical site on a large monitor, almost as big as that TV monitor, thus enabling a clear view of the intricate area. The lightweight 3D glasses are designed to allow surgeons and staff to comfortably move their heads without losing clarity of the image. Also in 2023, Lincoln Hospital became the first hospital in the state of Maine to introduce artificial intelligence in GI Genius. GI Genius, the first to market, computer-aided polyp detection system powered by artificial intelligence. Detect early, treat early. GI Genius has a 99.7% sensitivity in identifying colorectal polyps, which could be precancerous. Studies show that endoscopists with higher adenoma detection rates, ADR, during a screening colonoscopy more effectively protect their patients from colorectal cancer. GI Genius has been shown to increase ADR by up to 14.4%. Each 1% increase in ADR decreases the risk of interval cancer by 3%. Interval colorectal cancer is defined as a diagnosis of colon cancer within 60 months following a negative colonoscopy. As we continue to grow and embrace new technology, Lincoln Hospital is committed to working together so our communities are the healthiest in America. Recruitment of providers is important as we focus on community needs. A year ago, Lincoln Hospital hired fellowshipped hand surgeon Dr. Ross Feller. The addition of Dr. Feller has paved the way for Lincoln Hospital to perform surgeries that we have never done before. Without further ado, it is my privilege to introduce you all to Dr. Ross Feller. Thank you.
Thanks so much for having me. Thanks for the introduction. I think the entire time the thing that keeps ringing in my head is the quote that Cindy just used, small but mighty. And I think that's a perfect way of stating our operation here at Miles. Jess does a fantastic job in the OR. We're creating a fantastic squad, adding to a fantastic squad and growing the services here, and I'm happy to be a part of that. So I came here about a year ago, and in that small amount of time, we've established a pretty busy hand service that's growing, and we're really excited to see where it goes. So kind of getting things started, I'm Ross Feller. I'm an orthopedic trained hand surgeon. So basically I went to medical school, did my training in orthopedic surgery, and then decided to do additional training in hand surgery. And I don't know if I'm supposed to be looking at the crowd or at the cameras, but there's people that came here to see me, so I'm going to look at the people that are here. Sorry for the folks on camera. But so basically did that training in orthopedics. I did that down in Rhode Island where I grew up. And then I decided to do additional training in hand and upper extremity surgery. And so I went and did an additional year of training in hand surgery. Anything from, we're talking the things that we're going to be talking about today, right? Carpal tunnel syndrome, very common things, very, very, very common, very frequently done surgeries, to very rare surgeries like tendon transfers and doing deformity corrections in kids, and everything in between. Fractures of the wrist, arthritis of the base of the thumb. These are the kinds of things that hand surgeons see and treat, everything from simple to complex. So today we're going to be talking about carpal tunnel syndrome, but I could easily talk to you about the thousands of different things that I see and treat, and I'm happy to come back at any time and talk about any of those other things. But so essentially I started off down in Portland, and I built the hand program down there over the last 5 years. And then my brother and my brother is an ophthalmologist, and he was here I think a couple months ago doing a similar session. Decided to move up to the Midcoast, start a family, and practice together up here. And so it's been just a real blessing to be here and start another program and watch it grow and flourish, having that kind of foundational experience from where I came from. Basically, we'll get down to the meat of the situation, so to speak, today, and that's carpal tunnel syndrome. And the way I think about carpal tunnel syndrome is there's about 20 people in this room right now. So everybody raise your hands if you've ever woken up at night with your fingers numb and tingling. Has anyone ever woken up at night with their hand numb and tingling? I don't believe that you haven't ever woke up with your hand numb and tingling. Okay, so of the folks in the room, the only two people that did not raise their hand are the young guys over here doing the filming. So we've all had carpal tunnel syndrome symptoms at some point. Carpal tunnel syndrome is basically a problem where a nerve is being pinched at the level of the wrist, and it causes numbness and tingling primarily in the fingers, okay? If we really want to get into the specifics of it, it's typically these three fingers, the thumb, the index, the middle, and half of the ring finger, if you want to read a textbook. But essentially, people have, with carpal tunnel syndrome, complain of numbness and tingling. And there's different kinds of numbness and tingling. There's chronic numbness and tingling that doesn't get better. It never goes away. Some people get to the point where they just can't feel the tips of their fingers. That's very, very severe carpal tunnel. And then there's the more mild carpal tunnel where folks are, kind of a majority of the people that go on about their lives will wake up intermittently and have some very vague numbness and tingling of their fingers and be able to go back to sleep, and it doesn't really cause an issue. So whenever I talk about carpal tunnel syndrome, I make sure to set the stage that carpal tunnel syndrome is almost a part of the human experience. We will all get it at some point in our lives. And whether it gets to the point where it requires treatment, requires you to see someone like me, it varies. But it is a very, very common thing. It is the most common thing that I see and treat as a hand surgeon. And I see literally thousands of patients a year with this problem and operate on hundreds of patients a year with this problem. So it's something that is very, very near and dear to my heart. And although it's the most common thing that I do, it's probably one of the most beneficial things that I do as a hand surgeon in terms of like giving patients back their quality of life and being able to do things with their hand. So although it's super common, it's also something that gets a great bang for your buck, kind of like what my brother does with cataract surgery. It's a super duper common surgery that really improves the quality of life for thousands and thousands of patients, and has really changed kind of a lot of the way we do things in outpatient surgery. So that's kind of carpal tunnel syndrome. Does anyone have any questions about carpal tunnel syndrome before I keep going? Go ahead, sir.
One thing you mentioned.
And what's your name?
I'm Tom.
Tom.
Mulder.
Okay.
One thing you just mentioned was half of your ring finger. This is a foolish question, I know, but vertical half or lateral half?
Kind of if you split the finger down the middle.
Okay.
But I always like to say, most patients don't read the textbook when they come in. So
Yeah.
most patients are not saying, hey, that half of my finger is numb. Some people do. Yeah. Most people say my hand is going numb. I'm waking up at night, my hand is going numb. When I start driving or reading a book, talking on the phone, running my snowblower in the winter, running my lawnmower in the summer, going on my motorcycle in the summer. All of these either repetitive or heavy vibratory type activities can really aggravate those symptoms. One of the things with carpal tunnel is that a lot of folks will wake up in the middle of the night, and I'd have to say I've come to learn from doing this for quite a while that I'd say the vast majority of patients that end up having their carpal tunnel treated is because they cannot sleep at night. They're waking up at night, they have to shake their hands out, hang their hand over the edge of the bed, walk around with their hand. I mean, I've heard all the stories, hundreds and hundreds of stories. But the thing is, the running theme is that really when you start interrupting sleep, that's a huge quality of life thing. And if someone cannot get a good night's sleep because they're walking around with their hand on fire and numb all night, that usually is a reason why people come to see me. We kind of went off a little tangentially, but did that answer your question?
Oh, yeah.
Yeah. Does anyone else have any questions before I keep going? No? So, we've talked, I kind of broke the talk down a little bit, and we've talked about symptoms, we've talked about the problem. The nerve is called the median nerve, and it's kinked at the level of the wrist, okay? And so one of the reasons that people tend to have symptoms when they sleep at night is that we all sleep with our wrists bent, okay? And I do have patients that come in, they say, no, I make sure my hands are out on pillows and they're straight all night when I'm sleeping. And I say, I don't know about you, but when I am sleeping, I am no longer conscious of where my hands are. But we all sleep like we're still in the womb, right? We all sleep like this. So elbows bent and wrists bent. And that can really kink the nerve at the wrist. And so one of the things that we do, a very crude and simple thing that we do for folks when they first come in, is we give them a brace to wear at night, right, to keep their wrist straight. And for more mild symptoms, that can actually be pretty curative for folks to the point where they don't require surgery. So that's one thing that we do for carpal tunnel syndrome non-operatively. The other thing that we do for folks in terms of non-operative treatment is we do cortisone injections under ultrasound. So folks that come in with more mild symptoms that don't want to have surgery, we're going to get into the surgical part and we'll talk about the surgery. But for folks that don't want to have surgery, where the symptoms are more mild and we don't need to rush to surgery, where the diagnosis is still not totally clear, we do offer cortisone injections into the carpal tunnel as well. So those are kind of the mainstays of non-operative treatment for carpal tunnel syndrome, are kind of bracing. Some folks talk about doing some exercises for carpal tunnel, and we do have therapists that we send folks to that want to work with a hand therapist. And then the other non-operative treatment is a carpal tunnel injection with steroid. Usually the steroid injection does not last forever, but it is an option for folks that either can't or don't want to have surgery. So those are kind of the two non-operative treatments. In terms of making the diagnosis of carpal tunnel, usually within 5 seconds of meeting someone, I can tell whether you have carpal tunnel syndrome or not, or whether the diagnosis isn't totally clear. I'd say from just talking to a patient, about 90% of patients can be diagnosed with carpal tunnel syndrome just based on that. And then for the other folks, in exam, maybe another 5% of the cases are identified on the exam. So in 5% of cases, I actually need something to confirm the diagnosis. And those two things that I get are either a nerve test called an EMG, okay, or we are now doing, this is kind of important to note because it's not something that's commonly known in the community, we are now doing ultrasound for diagnosis of carpal tunnel. The reason why that is important is that an EMG is a uncomfortable procedure. You have needles that are stuck into your arm to test the conduction of the nerves, okay? So it's not comfortable. You have like a sensation of shocks and little pinpricks and things like that. So number one, it's a patient experience and satisfaction measure that we're starting here in terms of trying to do more ultrasound, which has been shown to be equally good at diagnosing carpal tunnel. Number two, you don't need to go have another appointment with a neurologist because we have somebody who is doing that in our office, ultrasound, okay? Number three, it's less costly to the system and the patient, okay? And the best thing in today's day and age is that we get things done efficiently, right? So you do not have to wait 3 months for your referral to go through to then get your nerve test, to then have to make an appointment to come back and see the hand surgeon. We get it kind of all tied up here. And so that's kind of an interesting thing that we're doing at Lincoln Health, is really starting to use ultrasound more in our practice to diagnose carpal tunnel.
I have a question.
Yeah.
Are other facilities using ultrasound?
I think folks are starting to. Yes. I think across the country it's becoming more and more common. But certainly in this region, most folks were being sent for nerve tests. So this is all very, very new, which is great.
So why would doctors still be sending us for a nerve test if we could just go to you for the ultrasound?
Great question. So number one, it's education in the community, right? Making sure that folks know that there's a hand surgeon that can manage these things now.
So you need to let the other doctors who you work with know that then?
Yep. Well, that's part of doing, all these outreach and education things. But absolutely, letting folks know. And then two, there is still reasons for a nerve test. It's better at differentiating. The only thing I look at is the carpal tunnel with an ultrasound. So if there's a question of other things going on, the nerve test can be important. If someone has an issue at their neck, for example, the nerve test can be important. So there's still a role for it. But you're absolutely right. It's about letting people know that, like, the times they are changing, and we can do this. We can always do things a little bit better, I think. So, yeah.
Regardless of the procedure you use, are these treatments permanent, other than the cortisone, but you don't get growth again and back in on the nerve and short-circuiting it?
That's a good question. You can have recurrence. Usually it's about, you're hearing it about 15, 20 years after the original procedure. It's not super duper common, but it's also not unheard of. I'd say probably for every 20 or 25 carpal tunnel releases that I do, I'm doing one revision of a prior carpal tunnel release. So it's not incredibly common, but it does happen. I see it more because I think more people with recurrence of their carpal tunnel end up getting sent to see a specialist or a hand surgeon like myself. But yes, it can happen. Usually it's from recurrent scar formation over the nerve. Okay, scar just kind of builds up over time and becomes kind of compressive again. And so what I do in that scenario is if it's causing enough of a problem is I do revise that surgery, and I do several different things to try to make it not come back again.
Second part of the question, without knowingly having repetitive motions throughout my career, what would cause it in some people and not others?
Yeah, I think some folks they have a genetic predisposition given their architecture of their carpal tunnel, but at the end of the day, I see folks that don't do anything with their hands have carpal tunnel, and I see folks that are carpenters and manual laborers that don't have carpal tunnel. I think carpal tunnel, again, is a little bit of the human experience, and everyone's going to get it at some point. And then I think that some people are predisposed potentially to having a worse kind of course with it than others. But I think it's almost like sometimes I say it's like why do humans get appendicitis, right? It's because the appendix is there, right, to cause a problem. So that there's literally a tunnel where the nerve and the tendons that bend the fingers down run in a tunnel, and there's a very thick roof of that tunnel, and over time it just becomes a compressive thing. And so, yes, that's a great question. I don't have a great answer for that because I see people that don't do anything get carpal tunnel, But it tends to, we see it a lot in folks with the more repetitive type stuff, including typing, right? Which isn't necessarily what we would consider hard labor, but it's a very repetitive type activity. And if you think about it, all those tendons run with the nerve. And if you're aggravating things over time, it can cause an issue. So, any other questions at all? So, we've talked about the symptoms. We've talked about kind of some of the treatments that we do for this. And then now I think we can talk more about the surgical treatment of carpal tunnel syndrome, and we have some video clips and things like that we were able to get from the goodwill of having a patient who was actually having this surgery performed with her wide awake under local anesthesia. So that's something we'll be talking about, is that patients will often have this surgery, and many of the surgeries that I do just wide awake with local anesthetic and not really requiring anesthesia, which is awesome for a whole variety of reasons. So really quickly before we start that, when we talk about carpal tunnel surgery, there are various options, okay, for doing a carpal tunnel release surgery. Historically, before we actually figured out what we were doing with carpal tunnel surgery, there were massive incisions that were used, okay? Big incisions all the way down when we first started doing this, because we didn't know exactly where the nerve was being kinked, okay? Where was the kink in the wire that was causing the problem? Really, where can we get down to a small segment? And so large surgeries were done to try to treat this problem. And it's kind of like everything else in surgery, where over time we're trying to refine things and make them less massive, right? And so we've gotten down to the point where we can do this through a very small open incision, which is how I do it. It's about an incision about this big at the palm, and you'll see that in this video. Some folks do it endoscopically with a camera through a similar sized incision down at the level of the wrist. And then the other thing to talk about, again, is that some folks will have this surgery with a little bit of sedation through an IV, or have it wide awake with just local anesthesia, okay? The benefit of having it wide awake with local anesthesia is that you do not have to fast after midnight, right? You can take all your medications. You're not having anything where there's going to be an issue with swallowing or anything like that. So you can eat and drink. I joke around with my patients that I don't, well, Jess might not want to hear this, but I tell my patients you can bring your coffee into the OR for all I care. You can drink up to the point of surgery. It is cost effective, right? Because you do not have to hire and pay an anesthesiologist and pay for the medications and the staff required to treat a patient that's had anesthesia. Patients can drive themselves home after some of the surgeries, so transportation is easier, and you just don't have to recover from anesthesia, right? So even having sedation through an IV, a lot of patients will be groggy, nauseous, for the remainder of the day, and with this, essentially, patients can come and go and drive themselves to and from their surgery, which is fantastic. So, for patients who are candidates for that, that's a great option. And then for folks who would rather not be aware of the surgery or it's a more involved surgery, we oftentimes will do sedation for that. So that's kind of an overview of the different types of treatments and some of the kind of the different considerations when we're thinking about doing the surgery. And we can get started here. So now I just get to watch myself do a surgery and talk you through it. So this is a little easier. So basically, this is the operating room, and again, the patient is wide awake, and she obviously consented to us videotaping this and was a great sport. You don't have any audio right now, but I will always ask a patient what music they want to listen to during the surgery if they're wide awake, except for country music. Just kidding. You can listen to country music if you want. And so this is a tourniquet going on the arm. And so as a hand surgeon, I work around a lot of tendons and nerves and arteries and very small structures that I want to have a good visualization of. And so I very often use a tourniquet for my surgeries, and that basically keeps the field bloodless, meaning it is not actively bleeding, and I can see what I need to do during the surgery. And so that goes on the arm, and that's a tight wrap, almost like a blood pressure cuff. Okay. Oh, is that just Okay. Yep. And then now, this is like, the part that is uncomfortable and the worst part, and it lasts, 10 or 15 seconds. This is me giving the injection for a carpal tunnel release. Okay. Patients do pretty well with it. I've learned to do it in a way that is as painless as possible. Obviously, it's not painless, but as painless as possible. And so you can see she tolerated that pretty well. And this is just giving the local numbing medication so that then we can do the surgery. And so we can go to the next one. So there she is, and her hand is orange because of the solution that we paint on the hand to keep it clean and sterile during the surgery. So that's the reason for that. This is my assistant, a nurse practitioner named Heather Lemica, who I work with, who's actually pretty essential. And I could talk to you all day about the outpatient side of what I do. This is more talking about the inpatient or surgical side of what I do. But we do have a team, and we work very well together. And so Heather helps me out with surgeries in the operating room. Yeah, that was Derek, Cindy's son, who works with me very frequently and who's fantastic in the operating room. Very dependable. So now everything is nice and what we call prepped and draped. So the hand is nice and clean, the drapes are on, and we can go to the next one. This one's with audio. So today we're going to be doing a carpal tunnel release surgery, and carpal tunnel syndrome is a problem where a nerve running across the wrist gets kinked. It's almost like an electric wire that isn't able to send its signal down the wire because there's a kink in it. And that kink happens at the level of the wrist, and it happens in a place called the carpal tunnel. And the carpal tunnel is literally a tunnel. It's a tunnel where the nerve and some tendons run through. And so what I do with a carpal tunnel release is I just open up the roof of that tunnel and I give the nerve more space to breathe and that wire to fire its signal correctly. And it's a procedure that's been kind of refined over several decades such that we can do it through a pretty small incision, and we can do it oftentimes with the patient completely awake like we are doing today. Carrie, we're going to get started, okay? So I'm wrapping your hand with what's called an S-mark bandage to get the blood out so we can see everything clearly. So this gets all the blood out of the hand, and tourniquet can go up now. So we use a tourniquet on the arm so that we can see very clearly. Okay, go to the next one. So yeah, a couple things about it. So as you can see, I was actually talking to the patient, right? Like, when have you ever that's not a normal thing, right? So the nice thing about it is that it can be interactive, and you can walk a patient through the surgery. Some patients actually want to see part of their surgery. I do find it's helpful in some situations to kind of explain to a patient. For example, if I'm doing a tendon repair, I can kind of talk to a patient, show them their tendon repair in the surgery, and kind of talk to them about their therapy and what they need to do. It's actually quite amazing. But it does take a team, like the nurse is on the other side of the drapes, basically talking to the patient, kind of keeping them nice and calm, kind of just, doing a little schmoozing, essentially, keep everybody calm during the surgery. It's actually called distractive anesthesia. It's been coined a term. So you distract the patient while they're having their surgery, and it keeps everybody calm. And so here's the basically the small incision, like I said, at the base of the palm. And essentially what you do is you go down again to the roof of the carpal tunnel. It's a very dense structure called the transverse carpal ligament. And it's the surgery is so small that it's actually hard to see the surgery on this video. But basically you incise through the skin and then some fat, and you get down to the carpal tunnel and then incise. And so you're not actually trying to touch the nerve at all. You're just trying to make sure there is nothing that is pressing on the nerve, okay? And so here with my scissors, I'm basically very, very carefully and slowly teasing the nerve off of that structure that is pushing on it and releasing it so that it is no longer compressing it, okay? Again, it's that concept of a wire that is trying to send its signal, but it's kinked. And so what I'm doing is relieving that kink to let the nerve fire normally. Okay.
Question?
I'm basically an electrician of the hand. Yeah.
Is there a predisposition to getting it more in, say, the right hand than left? And if not, do you do both at the same time?
Yep, that's a great question. So I think it is more common in people's dominant hand. But there are plenty of people that come in with 0 symptoms in their dominant hand and plenty of symptoms in their non-dominant hand. They ask me that same question, and as I'm doing with you a lot today, because you're asking the right questions, I say, I don't know. I don't know why the non-dominant hand is so symptomatic, and you've been using your right hand your whole life or your left hand your whole life, and it's not bugging you that much. So I don't know. Doing both at the same time can be done safely. It is a much more difficult recovery. I tend to do one side at a time, but I will do them both at the same time. And the typical person that would be a candidate for that is the young laborer who really needs to get back to work and can't take 2 recovery periods off, and also the person that's going to be super duper well behaved after surgery and have a lot of help at home. But I'd say the more and more I do it, the less and less I'm doing both sides at a time, unless a patient really needs it. But it can be done safely. Yep. Any other questions before we keep going? Okay.
So it's relatively bloodless.
I joke. So stop right there. Stop right there. So that's, I joke, I'm scared of blood, actually. The only surgeon who's scared of blood. No, as a hand surgeon, we always use tourniquets, again, because we are operating around small vessels, nerves, tendons. It makes it much more easier to see things. But basically, this is the carpal tunnel contents here. It's actually not the nerve. The nerve is off to the side a little bit. But you can kind of just make out the edge of the ligament that I release, that structure that's causing the compression. It's this white edge right here. And so now this no longer has anything that is sitting on top of it, pushing on it. And so that's kind of the point of why I'm doing the surgery. Keep going. So you can stop it there for a second. So again, this is a little bit blurry, but right here is the edge of that ligament that I'm releasing to open up the carpal tunnel. And so it's a very basic concept. You're just trying to give an enclosed space more area. And so literally I just go like this. This is the skin. I get down to the carpal tunnel and I just go like that. And I give the nerve room to breathe. Okay? You can go to the next one.
Do you close it up afterwards?
Yes, that is the next. That's the next part. And so basically what I'm doing right now is I'm just passing an instrument into the carpal tunnel to make sure that there's nothing like a little band of tissue that's like a elastic band that's kinking the nerve anymore. So I'm just checking that.
How long does this take?
This takes me 7 minutes, 90% of the time. If I'm fast, 6 minutes, and if I'm slow, 8 minutes.
This is sped up, but it's got audio at the end.
Yeah. So it's about a 10-minute surgery. 10-minute surgery.
The prep is longer.
If left unattended, does carpal tunnel get worse with time and harder to correct?
Yeah.
Or is it hit a maximum interruption period and plateau there?
That's a good question. So just before I forget, so about 4 or 5 stitches go in. Those stay in for about 2 weeks, 10 days, 2 weeks, something like that. For patients that are going to behave after surgery, they just go into a soft dressing. Okay, for patients that might push things a little bit too hard, we always have this discussion with patients. We may splint the patient for about a week or so. But that about 2 weeks is the golden rule for stitches to stay in. Patients come into the office, we take the stitches out. You can go to the next.
Do you not want the audio from this part?
So a total of 4 or 5 stitches usually goes in. And that is, these are taken out in the office about 10 days to 2 weeks after surgery. And we start the patient with immediate motion exercises, having them move their fingers. And usually it takes a total of 2 weeks for the wound to heal. So we really have patients limit what they're doing for the first 2 weeks. And then usually it's another 2, maybe 3, up to 4 weeks for you to feel like you've fully recovered from this surgery. So I usually tell patients it's about a month to a month and a half to really feel like you're completely done with it. We are splinting here. Okay. So basically, it's about, most patients, I'd say you can thank you. And so you can see now I'm basically automatically the minute 0 after I finish that surgery, we're already starting range of motion exercises on the fingers to make sure the fingers don't get swollen and stiff, because that's the biggest thing that we run into post-operatively. And so we're talking that through with the patient. Again, it's wonderful. The patient's awake. We can have this conversation. It's really a kind of a very engaged process, which is cool about what I do as a hand surgeon. There's a lot of, for a surgeon, I have a whole lot of engagement with patients, both in surgery and in the office. So it's fantastic. And then again, the recovery, most patients, what I hear is about 4 to 6 weeks to be doing almost everything that they want to do. I'd say 95% of patients fall into that kind of zone of recovery. And that's including, like, I would expect someone who did a manual labor type job to be back doing that job at about that time frame as well.
So the spouse is going to have to do the dishes.
Yes, yes. I have all kinds of jokes for that one too. Yeah. Yeah, I've got almost, now I'm like, nearing a better part of a decade in practice, so I've got all my little, jokes and spiels and, all that stuff. You asked a question about progression. You asked a question about progression of carpal tunnel, and so that's a conversation I have a lot with folks. Yeah, sure. I mean, carpal tunnel, like I said, is a huge spectrum of disease. Anything from, the person who wakes up once or twice a month with their hand a little bit numb and going back to bed, to a patient who basically has no more what I call acute symptoms, meaning it's no longer burning and tingling and painful and related to activity. Patients can get to the state of like a chronic nerve damage type scenario where it is just numb. It is no longer burning and tingling, and very often patients will lose a good amount of muscle that helps power their thumb, and so a lot of folks will have significant weakness when they have very end-stage carpal tunnel. I could talk for a very long time about this, and we could meet over a drink if you'd like later. But basically, yes, carpal tunnel can progress. I do not have the crystal ball to tell a patient it's going to progress at this rate for you. I tend to base a lot of my treatment on the patient's symptoms. Okay, so just because a patient has a positive nerve test or an ultrasound, if they are having minimal symptoms, that does not mean that they require surgery. So it's always a discussion. But yes, carpal tunnel can be progressive, and it can get to the point where surgery becomes not very effective. And it's when it gets to that point that I'm talking about, where there is constant numbness, there's no longer burning and tingling, and you've lost a significant amount of muscle. That's where we start talking about, hey, there's probably been some chronic nerve damage here. Your nerve is not even getting angry anymore, it's just kind of asleep. And that's a very different scenario from somebody who comes in with kind of, the more acute symptoms, what I call them. You're waking up at night or driving and your hand starts going numb, things like that. And so that's a discussion that I have very, very frequently with patients because, not all carpal tunnel syndrome responds to the same to surgery. So there is something to getting to it a little bit earlier, but I don't do it like prophylactically either. So.
You're treating all 5 fingers at the same time, the nerves for all 5?
So oftentimes so like I said in the beginning, not everybody reads the textbook, and some patients will just come in and say, my whole hand feels numb. Technically, this finger is done by a different nerve that lives in a different place. And so that's why I was saying it usually spares part of the ring finger and the small finger. But again, to your question earlier, that's another reason to be getting a nerve test, is if you think there's another nerve involved, the nerve test can still have utility. Okay.
So where does the pinky one go?
The pinky is done by the ulnar nerve, which is everyone knows this one too, your funny bone nerve, right? You knocked your elbow and you get your zinger down your finger. It's because you hit your nerve that crosses the elbow. And so that's a different nerve, which I also operate on. And that's a different doc talk. Was there any other questions I can answer for folks?
So where would the incision be for that pinky?
That would be up at the elbow. Yeah. It can also be compressed down at the wrist, and that's a different problem called Guillen's canal syndrome. But again, that's kind of why I have a good job security, is because there's like so many different things that can happen in the hand, and it's this little tiny part of the body that is incredibly complicated. And so, lots of different problems can affect the hand. And that's why I can like hone my practice on a very small part of the body, because there's so much going on, which is what has always fascinated me and driven me to be a hand surgeon.
On the recovery,
Yeah.
how soon can you start doing things with your hand? I know you said full recovery is like
Yep.
so many weeks.
Yep.
How soon can,
Good question. So almost immediately you can do very light things. So I say typing, texting, brushing your teeth, combing your hair, feeding yourself, all that. What's that?
shoveling?
Shoveling would not be considered a light thing. But again, I'm a hand surgeon in Maine, so I'm very accustomed to these conversations, and we figure things out. Light stuff. Couple pounds lifting, and I think the most important thing is making sure that you don't put your weight through your hand. I think a lot of people forget, because it's not a very painful procedure, and it's you're kind of in and out, and it might seem like it's not that big of a deal to some folks, but if you put your hand down, you put all your body weight through it, you could have an issue with your wound. And so that's kind of the big one I make sure I talk to folks about. But yes, like chopping wood, kayaking, shoveling, all the fun things that you do in Maine, you have to put a little bit of a kibosh on it for a very small amount of time.
I know this is about carpal tunnel, but you want to speak to the cases that you are bringing in that we've never done before?
Yeah.
Electric case?
Yeah. So one of the cool things about being a hand surgeon that is one of the reasons why Jess and I thought that this would be a successful thing, to bring like a subspecialist to a more community level place, is that I do a huge range of things that are done as outpatient surgeries, and so that mixes very well with a small and mighty operating room, where I can basically get a lot of stuff done. Everyone goes home, and we don't need big ancillary ICUs, things like that for our post-operative patients. Okay, so that's why I think that this works very well, to have a kind of a super subspecialized person in a place like this, and be successful. In terms of the things that I do that haven't been done here, we're doing like a lot of major nerve reconstruction and nerve transfer work that hasn't been done here. I do one of my big passions in hand surgery is pediatric and congenital hand surgery, and so we've done some of those cases here, which is pretty incredible. We've even done a syndactyly case here, where there was a young patient with their fingers fused together, and we separated those with skin grafts, and that's pretty amazing that kind of stuff is being done here. Tendon transfers for patients with cerebral palsy, and just a whole gamut of things. And so it just works very well. I can't say it any other way, that a lot of subspecialties would not be well suited for a smaller community level place, but it's perfect for a hand surgeon. So we're doing it all, and about 80% of what I do is the kind of stuff that I'm talking to you guys about today, what we call the bread and butter of hand surgery, right? Carpal tunnel releases. I do a lot of work with trigger fingers, which is something that is incredibly common, and thumb arthritis, wrist fractures, all the things that are super duper common, but we're also doing things here that are not common, and we're pretty proud of that. So we're going to keep doing it. Okay. Well, I think that's a wrap. Thank you guys for coming. I appreciate it.
Thank you.
Yeah.
Hager Enterprises, a paving and excavation contractor specializing in all sorts of site work, utility installations, and road construction since 1987.
When Tidewater Telecom built Lincoln County's first fiber-to-the-home network in 2011, we knew we were starting a project that would take years to see through. 9 years later, we are proud to have connected more than 2,000 Lincoln County homes to our blazing fast open fiber network. But that hasn't dimmed our vision to connect all of Lincoln County. Learn more about the power of fiber optic internet at tidewater.net.